actually get the mics and stuff. Solid. All right. Let's do our audio checks. Make sure this is streaming. Waiting for this to connect on YouTube. Looks solid. Okay, cool. Let's go ahead and get started. So welcome back to the weekly live streams. I actually just finished another live stream on the Pharmacy Informatics channel, so it's like back to back. This is fun. Anyways, guys, we'll jump right into it. We're gonna cover, as our usual, pharmacy news in the first 30 minutes, and actually no, the first 15 minutes, because these are 30-minute live streams, and then informatics news in the last 15 minutes. So we're gonna jump right into it. So let's go ahead and pull up the ASHP daily briefing for today, and let's see what kind of news we got. So let me see here. Let me pull this up over here on this side. Oh, it's actually doing this. One second. Let me move this over here. That's better. All right, let's read through this to see what kind of news we have today. Leading the news in the ASHP daily briefing, U.S. COVID-19 death toll surpasses 100K. That's a lot of deaths. Reports that the U.S. COVID-19 death toll topped 600,000 on Tuesday, even as the vaccination drive has drastically brought down daily cases and fatalities and allowed the country to emerge from the gloom and look forward to summer. The losses eclipse the population of Baltimore and is about equal to the number of Americans who died of cancer in 2019. Wall Street Journal reports COVID-19 related fatalities have plummeted in the US in recent weeks. Globally, more than 3.8 million fatalities have occurred. According to the New York Times, though the sheer number of deaths in the United States is higher than anywhere else, the country's toll is lower on a per capita basis than in many European and Latin American countries. I guess in some ways, that's good news, but it's a lot. Okay. What does this do? Oh, cool. Shows chat. Sorry, I'm getting a little distracted here. All right, moving on. Other COVID-19 news. COVID-19 was already in U.S. at the end of 2019. NIH study finds. Washington Post reports a National Institute of Health research study has turned up evidence of possible coronavirus infections in the United States as early as December 2019, weeks before the first documented infection in this country. Published in Clinical Infectious Diseases, the new research bolsters earlier studies indicating the virus entered the country under the radar and may have been spreading in the first 2 months of 2020. That's crazy, man. Well in advance of warnings to the effect from the Centers for Disease Control and Prevention. Wall Street Journal reports the study used NIH blood samples to conduct its analysis. The AP says the analysis is not definitive and some experts remain skeptical, but federal health officials are increasingly accepting a timeline in which small numbers of COVID-19 infections may have occurred in the US before the world ever became aware of a dangerous new virus erupting in China. Delta variant is of concern and currently accounts for 10% of new US COVID-19 cases. So reports the Delta coronavirus variant now accounts for nearly 10% of new cases in the United States, CDC said Tuesday. Therefore, on Monday, the CDC declared the variant, which was first detected in India, a variant of concern, a designation given when there is increased evidence of factors such as transmissibility or severity, reduced effectiveness of vaccines or treatments. Reports the Delta variant is believed to be about 60% more transmissible than a previous variant known as Alpha. I think this is the one where they talked about the vaccines were effective against, though. So maybe it's more so the people who are unvaccinated that should be worried about that. Anyways, quarter of people who had COVID-19 sought care for new medical problems at least a month after diagnosis. Hundreds of thousands of Americans have sought medical care for post-COVID health problems that they had not been diagnosed with before becoming infected with the coronavirus. Health insurance records of almost 2 million patients who contracted COVID-19 last year The study found that 1 month or more after their infection, almost 1/4, or 23% of them, sought medical treatment for new conditions. The most common health problems of those affected were pain, including in nerves and muscles, breathing difficulties, high cholesterol, malaise, and fatigue, and high blood pressure. It's really scary to think about. Okay, continue to move on. Regulatory. HHS seeks to rescind Trump rule on insulin and epinephrine discounts. HHS wants to rescind a Trump administration drug rule requiring community health centers to give all their insulin and epinephrine discounts to patients. Facilities which failed to pass on savings wouldn't qualify for federal grants under the rule. Under President Biden, HHS has delayed the effective date of the rule until July 20th to give agency officials more opportunity to review the rule and ensure it wouldn't impede the agencies and health centers' immediate priority work of responding to the pandemic. I don't think I completely understand that. FDA expands approval system for treatment of acute full thickness. Not interesting. MedPAC urges Medicare to streamline APMs. Yeah, alternative payment models are interesting. Let's see, so MedPage today reports the Medicare Payment Advisory Commission said in its annual report to Congress on Tuesday that Medicare needs to streamline its alternative payment models portfolio. The group's recommendation on reducing the number of APMs states that the Health and Human Services Secretary should implement a more harmonized portfolio of fewer alternative payment models that are designed to work together to support the strategic objectives of reducing spending and improving quality. However, the recommendation doesn't specify a number or even a number range of APMs for the Secretary to aim for. I think my recollection is alternative payment models is just to incentivize people to move away from fee for service. So just simply paying for some service you receive in healthcare. So this is supposed to spark value. To incentivizes providers to provide value, not just exchange services for a fee. But from what I recall is this is so confusing and so somewhat limiting in some ways that I guess they're trying to make it better. Research, boring. Not interested. Charity, also in the news, charity to pay $278 million of patients' hospital debt changes way accumulates patient debts. The Hill reports RIP medical debt through a partnership with Balad Health will pay off the medical debt for roughly 82,000 individuals previously served by the health network, totaling $278 million. Balad Health said that this is the first time RIP will buy out medical debt directly from hospitals. It has historically acquired accounts from debt buyers, collection agencies, and other groups in the secondary debt market. But a July opinion from HHS said that hospitals and physician groups may sell or donate medical debts directly to RIP for the purpose of abolishing a patient's liability under certain conditions. So one, I think that is super awesome, right? It's so easy to go bankrupt in America because of healthcare costs. Secondly, I think it's crazy that we have these insane healthcare costs. Something should be done about that. Okay, I think that's it for ASHP pharmacy tech news. Let's go ahead and move on to informatics news for today. Which one is it? This one. Okay, let's dig in. Top news today. Ganti installed as 229th president of the Medical Society of New Jersey. Kennedy Ganti was recently installed as the 229th president of the Medical Society of New Jersey at a virtual meeting held Sunday for the Society's annual elections. He's also a member of the Academy of Family Physicians, AMIA, and American Medical Association. Why is this the top news? I have no idea, but I guess it's... Let me look into that article a little closer to see if there's anything that is of interest. Face to the name, Kennedy Ganti. So why is this the front page news? He's installed as president of Medical Society of New Jersey. Poised to lead the Garden State in developing new normal when it comes to our state's healthcare landscape. Working collaboratively with battle with COVID-19. Diplomat of the American Board of Family Medicine, Board Certified in Family Medicine, Clinical Informatics. Currently, Dr. Ganti serves as the president-elect of New Jersey HIMSS, New Jersey chapter of the HIMSS, and is the chair of the advisory committee for One Health New Jersey. He's also a member of the American Academy of Family Physicians, blah, 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 served as past president. I have no idea why this is top news. I mean, congrats, but I don't know why that's top news. All right, let's switch back. Strange why that was chosen. Could a nasal spray of designer antibodies help to beat COVID-19? There's now several monoclonal antibodies, identical copies of a therapeutic antibody produced in large numbers that are authorized for the treatment of COVID-19. But in an ongoing effort to beat this terrible pandemic, there's plenty of room for continued improvements in treating infections with SARS-CoV-2, the virus that causes COVID-19. Apple struggles in push to make healthcare its greatest legacy. Apple chief executive Tim Cook has said the company's greatest contribution to mankind will be health. So far, some Apple initiatives aimed at broadly disrupting the healthcare sector have struggled to gain traction, according to people familiar with them and documents reviewed by the Wall Street Journal. Anything with Apple and health is always super fascinating. So let's take a look at this article a little closer. Where is it? It is this one. Oh no, it's behind a paywall. Damn it. Let's see if this is anywhere else. This is Wall Street Journal. I hope there is somewhere else. I can access this somewhere else. Nice. You're on Fox Business. So they say no ads. Yada yada. Apple has envisioned an audacious plan for healthcare, offering its own primary care medical service with Apple-employed doctors at its own clinics, according to people familiar with the plan and documents. To test that and other bold healthcare ideas, it took over clinics that catered to its employees and built a team with scores of clinicians, engineers, product designers, and others. Today, those ambitions, which aren't widely known, have largely stalled as Apple has shifted the focus of its health unit to something it knows well, selling devices, specifically the Apple Watch, according to people familiar with the strategy. The new primary care service hasn't gotten off the ground, people familiar with it say. A digital health app launched quietly this year has struggled to keep users engaged, say people familiar with the app and the documents seen by the journal. Some employees have raised questions internally about the integrity of health data coming from the company's clinics that has been used to support product development, according to people familiar with their concerns and documents. An Apple spokesperson said data integrity is the foundation for all the company's innovations. He pointed to the accomplishments of its health team and said the company is still in the early innings of the work in healthcare, adding that new technologies such as heart rate notifications and products like Apple Watch have improved users' health. He said data gathered by Apple's devices is enabling new research that has the potential to improve care. Many of the assertions in this report are based on incomplete, outdated, and inaccurate information, looking for new markets where technology can improve efficiency and outcomes and power sales growth. The tech sector has eyed healthcare as an untapped opportunity. Some of the tech's biggest efforts have failed, including Haven, Amazon's high-profile partnership with other companies that aim to reduce healthcare costs. Today, Amazon has a new effort to sell prescriptions and a plan to launch virtual care across 50 states. Under Mr. Cook's leadership, Apple has increased its research and development budget eightfold to $20 billion annually, according to its public filings. And besides a smartwatch, the company has released wireless headphones as well as new services. It has also invested heavily in health, autonomous driving, and augmented reality, all technically complex, high-stakes areas, meaning that game-changing offerings could be years away or never come. Apple can study markets for years before coming with its own offering, and it sometimes works extensively on new projects or technologies that it ultimately doesn't bring to market. One of its most ambitious healthcare ideas was a plan to offer primary care medicine, conceived in 2016, according to documents and other people familiar with the plan. An Apple team spent months trying to figure out how the flood of health and wellness data collected from users of its smartwatch, first released in 2015, might be used to improve healthcare. Apple Chief Operating Officer Jeff Williams, who oversees the health team, urged employees to think big. He said Apple should disrupt what he called the 363 and break-fix model of healthcare in the US, where patients may not see their doctors 363 days a year and only visit when something goes wrong, according to people familiar with his ideas. The team decided one of the best ways to realize that vision was to provide a medical service of its own, said people familiar with the plan, linking data generated by Apple devices with virtual and in-person care provided by Apple doctors. Apple would offer primary care, but also continuous health monitoring as part of a subscription-based personalized health program, according to these people in the documents. If Apple could prove that combination of its device sensors, software, and services could improve people's health and lower costs, the company could franchise the model to health systems in even other countries. I think many of these tech companies, even as we've seen with like Haven and their partnerships with the other companies like JP Morgan and Berkshire, they're overly ambitious. Tech can solve a lot, but tech itself can't solve the crises that we have in healthcare. You really need people that have backgrounds in healthcare and tech to do a good job. You can't just be recruiting healthcare people and expect it to work. You really need people that can speak the language of both. But this is very fascinating though. I saw a lot of postings a couple of years ago, I think 2-3 years ago, where Apple is trying to recruit a ton of clinicians to help with these initiatives. But super fascinating. Super fascinating. I am curious. I am betting and hoping that they will be able to tackle these problems. But I think the people that will finally fix these kind of problems don't exist yet. There's not anyone that I know that is smart enough, or just in my opinion, to know all of the details that can solve those problems. It's just very complex. But eventually we'll get there. I have hope. Okay, moving on. NIH study suggests coronavirus may have been in US as early. So we read that at first. Study explores usefulness of NFL as biomarker across range of, that doesn't sound interesting. Clinical informatics. In the wake of the pandemic, a wish list from informaticians. This is interesting. I don't know what this is about. Let me switch over to that. Just take a gander at what this is. A wish list from informaticians. All right, what is our wish list? So during the Precision Medicine World Conference, informaticians described the rapid progress they made harnessing the EHR data, as well as their hopes for improved public health infrastructure. Informatics executives are making a valuable contribution to the pandemic response through the collection, dissemination, and analysis of EHR and clinical registry data. During a recent panel discussions, leaders from several health systems also described the challenges and shortcomings they faced and a wish list for the future. The June 15th Precision Medicine World Conference panel was hosted by Atul Butt, who is the former Haven guy, I believe, right? Actually, no, maybe not. It's not. I got confused. He's someone that I've seen a lot in AMIA. Director of UCSF's Institute for Computational Health Sciences. He asked his panelists to describe some of their accomplishments during the COVID era, and each respondent described significant changes their teams were able to make in short order. For instance, Melissa Hendel, Chief Research Informatics Officer at the University of Colorado, who leads the National Center for Data Health, described the number of people who came together to harmonize and aggregate data to create the National COVID Cohort Collaborative, N3C, which aims to take EHR data and harmonize it and bring it together and make it broadly accessible. One of the overarching goals of this initiative was to create a fully transparent, reproducible, and broadly accessible electronic health record data repository of COVID patients and match controls being drawn from a variety of different clinical institutions. We're up to 90 institutions now that have signed onto the initiative. We now have over 2,000 people working on it. It demonstrates the sort of commitment and partnership between the community members, the research networks from the different common data models, the government centers for translational science award sites, and commercial entities all working collectively together in a rather unprecedented governance structure to enable the creation of this limited data set, which to our knowledge is now the largest publicly available limited data set in US history. That's very cool, man. Let me see, is there more? Where's the wish list? Just read the last paragraph. And they'll close by noting that a few of the themes that were mentioned included centralization and identifiers. It's all about being able to harmonize information for asking important questions. In the face of a new disease, we really want to take advantage of all the different data that we can about an individual in a population. In healthcare, we take data that is about a patient. Now we have EHR data, we have imaging data, we have viral sequencing data, we have survey data. We ship those data to different places, never to be reconnected again. And so my hope in the future is that we have a system where we can put the people back together again. My very technical term, to do the multimodal analytics, get the imaging machine learning working together with the clinical data at the scale of the whole nation. That really takes the management of centralization into the state or the national level, and really good identifier management for security as well as for data analytics. Wasn't exactly what I was looking for, but that's okay. I thought there'd be something more tangible to tap into. Let's go back to our article here. Where's our article? Here it is. Okay. With analytics, healthcare can get more from its investments in FHIR. Analytics on FHIR is a real-world example of how applying open standards to healthcare data can deliver near real-time insights for better care management and operational efficiencies in healthcare. I only have 8 minutes left, so let me just scan back. I might go back into that one. AWS leader talks about technologies needed to take precision medicine to the next level. One of the most significant challenges to the advancement of precision medicine has been the lack of an infrastructure to support translational bioinformatics, supporting organizations as they work to uncover unique data sets to find novel associations and signals. I think like the first thing, I mean, this is probably like a simplification. I feel like the first thing I think about with this is like CPIC, you know, where the members of CPIC help to translate the work that's done in precision medicine to the bedside. But maybe I'm like thinking wrong. Does digital health fit with your strategy? Digital health products and services can be traced back to early predecessors, such as electronic medical records, which set the stage for exponential leaps in capabilities. Not interesting. Morning talks. Regeneron antibody saves lives in some hospitalized COVID patients. A monoclonal antibody treatment for COVID-19 developed by Regeneron saved lives among hospitalized patients who had not mounted their own immune response, a finding that could dramatically change the way that doctors will use the therapy. That's good. Type 1 diabetes, fine mapping, not interesting. Autism sharing initiative brings federated data model to research. A coalition of researchers and healthcare providers in Canada and beyond are building what they believe to be the first global federated network for sharing genomics and clinical data to support advances in research and patient care for autism. That's awesome. Deep learning network predicts adverse cardiac events. 4 ways machine learning is fixing to fine-tune clinical nutrition. Clinical nutritionists won't be left out of the medical AI revolution, as researchers are exploring use cases for augmented diet optimization, food image recognition, risk prediction, and diet pattern analysis. Many post-COVID patients are experiencing new medical problems. I think we read this in the other one. Yeah, I mean, essentially they're finding that there's long-term sequelae when patients have had COVID-19. So just because you have COVID-19 and recover doesn't mean you're out of the woodworks yet. And again, this is what scares me about catching COVID, is like we don't know what are the the long-term issues, and it looks like there's more and more being found. COVID-19 live updates surpasses 600,000 deaths. We saw that at first. Biden admin moves to axe Trump 340B rule targeting community clinics. Biden administration Tuesday moved to axe a Trump-era policy that would have targeted federal discounts for clinics serving low-income people. I didn't know they were trying to, well, I guess I knew they were trying to axe it, but I didn't move to axe. That's good. We want to keep 340B. Pfizer is studying vaccinated people who get infected for insights on boosters. Pfizer is studying the rare cases in which vaccinated people have gotten infected with the coronavirus in order to determine when booster shots. Oh, this is interesting. This isn't so much informatics, but good to take a look at it. Let me share that article. Let's see if we can glean anything interesting here. Pfizer is studying the rare cases in which vaccinated people have gotten infected with the coronavirus in order to determine when booster shots might be needed. We'll be looking at real-world data to help us understand when we might see a change in vaccine effectiveness. We're going to be monitoring this closely and using immunological data, clinical data, and real-world data to help us think about when a booster might be needed. Dr. Fauci, the director of the blah, 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 said in May that booster shots for the coronavirus will most likely be needed, but it is not clear exactly when. 2 studies suggest immunity from the vaccines could last at least a year. Okay. We're working on understanding the impact of booster doses. We will be getting data from continued monitoring of our clinical trials to see how long immune markers last. As of end of April, there will have been more than 10,000 cases of individuals who have been infected with the virus after getting the Pfizer vaccine. 10,000 cases of people getting infected with the virus after getting the vaccine by the end of April. That's interesting. Yeah, this is going to be very interesting to know what it's going to look like post-pandemic. You know, this could be like an annual flu vaccine kind of deal. And if that's the case, then how does that impact pharmacy jobs, right? I think a lot of us, or at least myself, thought that the boost in pharmacy jobs due to the COVID-19 vaccinations was going to be temporary, but no, actually, you know what? Yeah, I don't know. I just know that a continued annual vaccine, something like this, is probably going to make it more difficult for our retail pharmacists. Or maybe it won't be as bad because there won't be as much of a rush, you know? But I don't know. AKA Cry says, hello. What's up, man? Let's go back to the article again. NC chooses 3 regions for Medicaid Healthy Opportunities pilots. As state prepares shift to Medicaid managed care, pilots will test evidence-based non-medical interventions designed to reduce costs, improve health of Medicare beneficiaries. I want to read this, but I don't. Let me go back up to the one that I wanted to look into more. We're actually about to run out of time, so this might be the last one. Let me click into it. See if there's anything interesting. With analytics, healthcare can get more from its investments in FHIR. By now, most people in the healthcare industry understand the purpose of FHIR, a data sharing standard for exchanging health information electronically. Why is FHIR important? Simply put, if you have 2 data sources, you need them to talk to each other. FHIR can help accomplish that goal, but healthcare organizations can get a greater return on investment if they go beyond enabling 2 things to talk through data exchange. Implementing a FHIR server or application programming interface API is often how organizations meet regulatory requirements and is an important first step on the journey to interoperability. This effort can require a lot of resources, including financial, time, and talent, and healthcare organizations should think beyond the mandate to get more out of this investment. What is this linking to? Interoperability mandate. Yeah, I mean, I'm assuming they're referencing the 21st Century Cures Act, the regulations of it. In my role as informatician at my hospital, I was part of a team asking the question, what more can we do with the FHIR healthcare data we're exchanging? We've been working to connect several tools, and we're adding FHIR input and output capabilities to an EMR. That's when we realized that FHIR is JSON, which is structured text, and we can analyze text at scale. That was a huge leap forward for us. Traditionally, we would have to take healthcare data out of a database, standardize it, and bring it to an analytics package to analyze and produce a report. But we implemented a solution that streamed data to and worked directly on the FHIR server. Every time the EHR wrote to the database, it also instantly sent the FHIR resource that matched the record. Not only was this approach helpful for tools that needed to consume this health information, but had the potential to vastly enhance our analytics capabilities. We used a text indexing search engine for semi-structured text. Because the solution indexes information as it's written, queries go straight to the index, no coding required, enabling near real-time results with massive scale. This also obviated the usual database synchronization challenge between healthcare data sources and the analytics repository. Here are just a few examples of how organizations can apply FHIR-based expanded analytics capabilities for population health and program performance. Find real-time insights. We could manage the healthcare provider's clinic's workload more effectively, knowing near real-time answers to questions such as, how many patients checked in today? How many are currently roomed? How many were discharged? Improve data quality. Another benefit of implementing a FHIR server into your healthcare data strategy is that it encourages good data hygiene and standardization. Because FHIR requires validation against common standards to be interoperable. It lets you find deviations from the standard in your existing data pipelines. Address gaps in care. The server can help teams manage quality measures, cohort definitions, and other tasks to help address gaps in care. Let's say a clinician calculates a neuropathy risk score as part of the HR workflow. FHIR extension could add this information to the patient's record of visit. Integrating social determinants of health. Understanding more about where the neighborhoods patients are coming from could help tailor population health efforts. Adding GPS coordinates of home addresses and loading SDOH as extensions onto the FHIR server can enable population-level analytics. Delivering insights at the point of care. Return those expensively created care metrics back to the point of care rather than a report sitting in a file somewhere. Having risk scores and cohort information at the point of care provides a significant ROI for this process. Essentially, FHIR servers can extend the value of the clinical and administrative data that healthcare organizations are exchanging. It can enable organizations to move beyond regulatory compliance and release constraints of a traditional approach, where analytics are confined in periodic reports. It can make health information more valuable to organizations on a daily basis. Whether it's a hospital, healthcare provider, payer, or government agency, a robust FHIR server can deliver agreement on data format and derive insights that can enhance clinical care operations. The door is open to countless new use cases. Cool. Very, very cool. All right. Interesting to read. Let's see. That's the news for today. I didn't find anything that was too interesting, but thank you guys that did tune in. This is the end of our 30-minute session. Sure to tune in again next week. Yeah, if you like the video, give it a like. And otherwise, I'll see you guys next week.